Closed captioning for Lakeland Currents is supported by the Minnesota Department of Commerce, Telecommunications Access Minnesota, and Nisswa Tax Service. Nisswa Tax Service, tax preparation for businesses and individuals. Across from City Hall in Nisswa and online at nisswatax.com.
Everybody, and welcome to Lakeland Currents, where tonight our topic is working from the outside in. No, we're not talking about bank robbery. We're talking about laparoscopic surgery. And I think you're going to see some things in this program that the average person on the street just never has an opportunity to see, and we hope that you'll find it informational and educational. My guests this evening are Dr. Patricia Mahoney, who is originally from Aberdeen, South Dakota, via 5 or 6 other communities I found out, not only South Dakota, but Wisconsin. And anyway, she went to medical school at the University of South Dakota in Sioux Falls. She did a residency in South Carolina. She is a general surgeon with a special interest in laparoscopic surgery. She now lives in Staples with her husband Lance and their 3 sons, Samuel, Andrew, and Daniel. Welcome to the show. And with her, also from the Lakewood, both of these folks are from the Lakewood Health System. Cindy Swenson, who is the Director of Surgery and Outpatient Services. She is an RN. She's a registered nurse with a very unusual background. She has a Bachelor of Science degree, Industrial Engineering and Management, which I must say I've never seen that combination before. It's odd. It is odd. She and her husband live in Burndale, Minnesota. Their son Eric and his wife Amber live in Fargo. Welcome to the show.
Thank you.
It's nice of you to come, and I know you've had a very, very busy schedule in the hospital, and it was nice of you to take some time to be here. Maybe we could just, before we get into the laparoscopic piece, what's it like in the hospital environment right now with the H1N1 and the other things that are going around?
Sure.
Is it pretty hectic?
It is very busy. The emergency room is busy pretty much 24/7 right now with the H1N1 people coming in with different types of flu symptoms. There are a couple flu bugs going around, one that is the influenza A or the H1N1 flu, but also there's kind of a gastrointestinal flu going around too. So we have patients coming in with both of those issues right now.
Dr. Mahoney, maybe you could just give us a little bit of a background. What's the difference between going to med school and becoming a general practitioner versus branching off and becoming a surgeon?
Well, you go through the first 4 years of medical school the same every place. The first 2 years are mostly the book learning, and you may, depending on your school, in South Dakota we actually did do clinicals where we would follow other physicians. And then the last 2 years are actually in the hospital. And in your last year, then you have to pick your specialty. So once you graduate from medical school, you're a doctor, but you can't get a license. Most states would say you have to do at least 1 year of residency. So it depends. You know, psychiatry is 5 years of a specialized residency. Surgery used to be 5 years. Most programs are now 7 because they include like a mandatory year of research also. And then you can do subspecialties beyond that. For instance, plastic surgeons can either do 3 years of general surgery and then 2 more years of plastics, or they can do an entire general surgery for 5 years and then do 3 or 4 years of plastics. And then there are different things if you want to do back or hand, and you know, orthopedics is the same way. You can kind of do everything if you do general orthopedics, and then a lot of people will come into a specialty or an area that they like more than another, and they'll specialize in backs or knees, and OB-GYN is kind of the same thing. You get the people who want to do the high-risk deliveries, and so, you know, you have to pick at the end of your med school, and then your residency is usually from 3 to 7 years, depending on the specialty. Family practice is 3 to 4 years in most places.
So as a general surgeon, are there certain surgeries that you cannot do or you typically do not do?
General surgeon means I can do anything. I've taken out brain tumors, I've taken out lungs, I've sewn on hearts, I've taken out kidneys, I've done cancer surgery. So I've done it all in certain rotations. I've even done interventional radiology where I was putting stents in and putting clotting agents in when someone was bleeding from their belly or something like that. So I can do all of it, but once you get out in private practice, there are certain things you don't do. Like in a larger place where they have orthopedics, I don't have to do hips and I don't have to do trauma, broken limbs and things because we have orthopedics here. And generally in a smaller facility, you're not going to do the heart surgery and things like that unless it's an emergency. So you do kind of narrow it down. So general surgeons in most of the smaller communities do general stuff, you know, gallbladders, colon cancers, skin cancers, breast surgery, things like that. And anybody that would require brain surgery or something would usually go to a specialist for that. But we are trained and we actually do rotations in all of those things.
I've been told by other friends in the medical community, to be a surgeon, you have to have two things. You have to have absolute confidence in yourself, and you have to have really great hands.
Exactly.
Is that true? Both
That's
of those
very true. That's very true. I mean, people have this bad attitude that surgeons have a God complex or are kind of cocky, but most people won't cut somebody else open and stick their hands in there and expect them to walk away. So you do have to be confident just to do what we do on a daily basis, and that involves the nurses too. I mean, they're standing there and they're helping us and they're handing us instruments, and they're responsible when I walk out of the room to make sure the patient gets up to their bedroom okay, and that type of thing. So I think everybody there has to be confident in their abilities, and they have to know what's going on so that the patient is treated safely.
So what is laparoscopic surgery for people who don't know?
Well, it would imply, I mean, just as though arthroscopic would say you used a camera in a joint, laparoscopic, lap means belly, so it means you're using a camera in the belly and you're doing, you know, whatever surgery you need to do there. So generally what we do is we gain access to the abdomen with a camera or with a trocar, which is basically a stiff straw, and we fill the belly with CO2 gas. And that distends the belly as though someone's pregnant, and that gives us room to work, and then we can visualize. So then we can do whatever we have to do in there.
So are you extending it by a lot or just by a small portion?
You ever seen someone pregnant with triplets? There you go.
I don't think so. I don't think I have.
I generally explain it to someone that they're going to look pregnant, and that's really what it is. Basically, from their rib cage to their pelvis gets very distended. Obviously, someone who's had babies before distends a lot more than a little, 130-pound guy that has a six-pack. Everything's relative, but yes, we distend them significantly. So everybody who has this surgery is actually asleep, because that's kind of the only sensation you have is stretch. That's kind of why gas pain hurts so badly. So everybody does have to be asleep if we're going to actually put gas in there.
So you put instruments into the holes that you create, but how do you see what you're doing?
And that's I bought some toys. The one who dies with the most toys wins. So this is an example of a trocar that we would use, and as you can see, it's shaped like basically like a gun, and with this hole here we actually can put the camera in, and what I do is I make an incision in the skin, and with this tapered end I actually push down almost like I'm rotating a gun inside the abdomen. And once I see that I'm in the abdomen, I see intestines, that type of thing, I actually pull the inner sleeve out, and through this stopcock I start to put the CO2 in. But this is see-through, and actually some of them actually have holes that let the CO2 gas in as I'm going, so I can see the tissue dissect away. Now this is nice because it's tapered. Although it's a 12mm hole, which will allow me to put staplers, cameras, mesh through it, it actually only leaves a 3mm hole when I pull it out, because it does not cut the tissue, it just pushes it away. And these are some other examples. This is a larger 12mm trocar also. And then this would be an example of a 5, and most of our instruments will go through a 5mm. I generally explain to my patients that, say when I'm taking their gallbladder out, 3 of the incisions under their rib cage will be the size of my pinky nail, because that's about 5mm. So once we take these out, we don't have to sew the deep layers, we can just close the skin. The risk of a hernia through that hole is probably less than 3%. Another example of a larger one, a larger trocar, would be this one. We would actually access the abdomen, and once we have it in the abdomen, we actually blow up a balloon, and this way we don't have to stitch it in place, and that balloon stays inside the belly, and then we actually loosen up this cuff and slide it down so it's tight, and that will hold the air in. And
so
then
the skin would be located between the two.
And then when we slide this trocar out, this one's nice because that can be a 12mm hole, which will fit a stapler, but I can put a 10 through that by sliding the diaphragm, and actually I can slide this diaphragm up and have a 5. So that's a multi-use instrument too, which is very nice. And then we brought some examples of some instruments that we use once we're inside the abdomen. For instance, if I want to grab a gallbladder or I want to grab intestine, I can use this. This is called a Babcock, and the tips are relatively atraumatic, and you see that they move quite easily. Just with spinning my finger, I can spin it around so I can grab any angle I want without dislocating my shoulder and moving it. And actually, if I grab onto tissue and I don't want to get my thumb tired, I actually can lock it and it won't open. So it will hold. So basically, I can have another nurse or something hold the gallbladder up out of my way by just balancing this. And then when I want to let go, I just click again.
How big is a gallbladder?
It depends whether it's distended or not. Average person is about this big. So it depends. It can get more distended.
That used to be really a major surgery, didn't it?
It is. And most of my patients go home within 3 or 4 hours of waking up now.
From gallbladder surgery?
Yes.
Wow, that's incredible.
Yeah, usually if they stay overnight, it's either because they've had other surgeries and a lot of you know, scar tissue in there or because the anesthesia made them sick. Occasionally people will react to the anesthesia.
Wow. That's
And it used to
incredible.
be a 7 to 10 day hospitalization with that, when it was an open procedure before laparoscopic came around.
So,
Wow.
there, and then of course there's the whole scar issue and pain issue and not being able to eat right away and all those things. My patients eat as soon as they wake up.
So is the pain usually from going through the actual skin portion of the body?
It's
As opposed to the
some of the
internal?
skin, but it's more the fascia. In other words, the thick layer, the ligamentous layer around the muscle, and actually getting into the abdomen with a large incision. Then you have a bunch of muscle spasm and muscle pain associated. So this minimizes that. And once, say we want to disconnect the gallbladder from the ducts after we have the titanium clips on, we actually have scissors or shears. And this is very similar to the other instrument, except it's scissors. And once again, I can rotate very easily and change the angle, which is very helpful. And this is called a Maryland, which is very similar only to the scissors, only it's not sharp. It's a grasper. But I can use this to separate tissue. I can put this between two things and slowly spread it, and that will separate the tissue, and the ends are blunt so it won't poke into anything. And once again, I can spin it. The nice thing is I can actually put an electric current through this attachment here. And so I can grab a piece of fat and I can buzz it, so to speak, by stepping on a foot pedal, and it will actually cauterize so that whatever I'm separating will not bleed. So we can make, you know, next to bloodless surgery, pretty darn close. So that's really nice. And this is useful for that reason too. This is called a ligature. It's very similar to a harmonic scalpel, but it uses more of the concept of friction and vibration and that type of thing, and it actually will precipitate the proteins in the blood and the blood cells in the blood vessels. And the harmonic scalpel's a little bit different setup, and the ligature uses a little bit, I guess I should say you can use it on a little bit larger blood vessel. So this I would use, say, if I was doing a colon resection inside an abdomen, I could go across the blood vessels going to the colon with this. And it's the same thing. You know, you can move this around and rotate it also, but it closes and clips, and then when I want to fire it, I just squeeze this, and I clip it back here with my thumb, and that turns on the coag, basically, or it coagulates. It will beep when it tells me the tissue is coagulated, and then I cut, and it actually slides down and cuts in between the tissues on that tip there. That little hollow right there is actually for a blade.
So it
actually will cut the tissue
it
once
seals on two sides
and then
cuts in the middle of those two.
Wow.
and so I have to pop it open again. And then, shall I hold that?
Sure.
This is an example of a stapler. So if I was going to remove some part of someone's bowel and I wanted to staple the two ends back together, say for a cancer or something like that, I would line up the bowel, and you know, like I said, toys are great. So this is a GI stapler, and you may not be able to see it too closely. There are actually 6 rows if you look on the blue side, and that's where the staplers are going to be. And the big row, or the big hole in the center, is actually where the blade will slide down. So what we're going to have is, we're actually going to have multiple levels, or multiple layers of staplers. And I don't know if I got this clicked on right. But, and the nice thing is this one actually reticulates. I can move it this way, but I can also, if I had it on right, sorry, you actually can angle this one direction or the other. And by pulling this back, it allows me to close. And I don't have it clipped on quite right there, sorry.
But anyway, you can do the stapling,
Right.
everything inside.
So this would, and this comes off, so then we can use the same instrument and just put a new stapler device on there. And like I said, it will lay down 3 rows of staples that stagger kind of like a zipper and then cut in the middle. So it actually will hook 2 loops of intestine together.
Okay.
And then one of the other things we have is called an endo stitch. And I don't know what engineer figured this out, but this is great. So when you take out a loop of intestine, you have a space between the fat that carries the blood vessels. That's called the mesentery. So you can imagine you're basically bringing it up and you're having a drape. As the intestines come together, well, there's a hole there. If you leave that hole in the mesentery, another loop of intestine can go in that hole and basically cause an internal hernia. And also you can sew in intestines with this or whatever else is in the belly. But if you can actually get an angle on this, it's great because you can toggle the needle. The suture is attached in the middle of the needle, and both ends are actually sharp. So you put it through the tissue, and with this finger, I just toggle it back and forth, and it passes to the other side. So by just doing this and moving down the tissue, I'm actually passing the suture back and forth, and I can actually sew on intestine and that type of thing in the abdomen without ever touching anything.
Wow,
That's pretty,
incredible.
that's amazing, isn't it?
It is
And of
amazing.
course, they're very long because, you know, you have to reach, you know, I have to put this through the trocar and then be able to pull it out. So that's interesting. And then one of the most common questions, besides how do you see in there and everything about how the gas gets in, people always want to know, so how do you get out my gallbladder or appendix?
take it out?
Exactly. They actually want to know the specifics. So this is the answer, because they look at me like I'm crazy when I say I put it in a plastic bag and pull it out of your belly button. That's what I really mean. So once we have the gallbladder disconnected from the liver and we're holding on to it, it's kind of free in the abdomen, I put this through one of these trocars, which is, you know, usually down by your belly button. And once I get that in there, I actually can open this up, and you see it's a little metal ring, and out pops a little plastic bag. And so I can put the, we'll just use a demonstration for you.
Motrin here.
Yeah, Motrin will work. So for instance, I put the gallbladder, the appendix in there, and then what I do is I close the bag. I pop this ring, and the suture ties the bag shut, and then I can close this. Now, some people will pull the whole bag out at the same time. Oftentimes what I do is I leave the bag in there, because otherwise it costs me an extra 3 minutes. I have to let all the air out and then put the air back in. So I'll leave it in there while I finish. You know, you go back and you look and make sure there's no bleeding and everything's cleaned up. And then when I take the trocar out, I pull this out and there's my gallbladder.
So the whole thing comes through that.
The whole thing will come out through here, right.
And this could be as big as a softball almost, I would guess. Huh?
Sometimes it can. If it's that distended, we have a couple of choices. We can either make the incision larger so we can get it out, which happens sometimes. Or a lot of times if the gallbladder is that distended, we'll actually drain it beforehand. We do have needles that are, the actual needle's only this long, but they're on long tubes like these instruments, and we actually will suck the gallbladder out or aspirate it beforehand, and then it will fit through the hole. And then we have the other suturing device. This is an example of another device we would use. For instance, if you needed to tie something off, you had a blood vessel or the duct going to the gallbladder, and you were uncertain about that. That's actually pretty sharp. Let's use this. Okay. So this is called an endo loop. And just as an example, I would put this down the trocar, and I would basically use a grasper to pick up this end so that I had this controlled. And this end back here actually pops and cracks, and then I can pull the suture down. So then what I do is I slide the white tube down to whatever structure I'm trying to tie on, and I cinch up my knot. So it's like I lassoed it.
Wow.
And then once I do that, I back this off. My knot is then tight. I back it off, and then through one of the other trocars, or even that same trocar, I slide down my shears and cut it.
Wow.
So it's interesting. We can do a lot of things. People think, well, what are you going to do if it bleeds? How are you going to tie it off? I have lots of toys. There are also clips, you know, little metal clip that will staple. And then there's another instrument we use, and we use this during hernia repairs or closing trocar sites. This is called a Carter-Thomason. And if I needed to reach inside and grab a suture, say this is an example of a piece of mesh. If I wanted to pull the mesh up to the belly wall to fix someone's hernia, what I would do is put a couple of sutures in the corners and figure out where on your belly I wanted to go through. I actually can, because it's sharp like a needle, I actually can poke through the belly wall, and then if I pull back like that, that little needle opens up. I can grab the suture and pull it back out through the front of the belly wall. So that will pull my mesh up so it's tight against the abdomen. And then through these trocars, I actually can put little stapling devices and staple the mesh to the anterior abdomen.
Do you eventually have to take this out then?
Nope, that's a permanent
dissolves?
thing.
Oh, it's permanent?
Yeah, that's permanent. And that's one example. That's like a PTFE, they would call it, kind of a Teflon-y kind of material. There are some that are more like a 3-level or a 3D kind of polyester. And then there's some that we call biologics. In other words, from cadavers, they would actually harvest the dermis and the skin basically, and then they put it through certain chemical things, and they actually take the cells out of them. So all you have left is the collagen matrix that doesn't really have any live cells that you can react to as far as your immune system. And I always explain to people, it's like when you have the steel work up but you haven't put up your sheetrock yet. That's kind of what the biologics are like. And the nice thing about those is since they're not cells and your body does basically absorb them and put down its own tissue, it actually melds into your tissue and is not considered a foreign body. So those are nice if you have somebody who has an infection or a perforated colon or something like that. You can actually use the biologics in face of an infection. If something like this were to get infected, let's say you had it in and then you perforated a colon or something like that and you got caca on it, it would automatically be infected, and just like you know, just like an artificial knee that's infected, any foreign body has to come out. And taking the mesh out once it's been in there a few years is rather difficult.
I bet. What do you do if you have an unexpected problem? And let's say there's bleeding somewhere that you didn't expect. Can you deal with that with this level? You still can.
Yeah, I've been surprised a few times. I think about a year and a half ago, I actually got actually was just doing a gallbladder on my nurse's sister, unfortunately, somewhere else. And when I put in the camera, all of a sudden there was blood everywhere in her abdomen. Oh, and I was like, okay, this is old blood and I didn't cause it. Where did it come from? And what I eventually found out is two things. First of all, her gallbladder was bad and I took that out because the bleeding was old and it wasn't ongoing. And what I found is she actually had a small crack in her liver, and she also had an ovarian cyst that had ruptured. Evidently, she'd been snowmobiling the week before and fell off in an accident and didn't tell her father that she actually got hurt. So, I mean, I appropriately took out her gallbladder and I cleaned up everything else, but every once in a while you get surprised and you find something unexpected, or you go in to fix a hernia and you find something that makes you think of a cancer, and so you unexpectedly have to biopsy something else, or something along those lines. So we always try to prepare the patients for that anytime we start off a laparoscopic procedure, you have to understand that it could become a standard or an open procedure. If I can't see what I want to see, if something I find is different, I can't fix it appropriately, whatever the case may be, then they may have to get open. And every once in a while we do find something totally unexpected, and we may actually leave the room and go talk to the family to get permission, to do something else. And occasionally that happens.
There are products also that, such as Seal or Flow Seal are some brand names that Dr. Mahoney can spray inside through a trocar to seal up some small bleeding issues if it's not a large vessel that's bleeding or something like that. So we have some of those kinds of tools in the toolbox too.
Is this getting to be common in most hospitals, or is it still a specialty that is found in a select few?
It depends on exactly how extensive you want to be. Almost all general surgeons anymore, even the ones that are getting ready to retire now, have experience laparoscopically taking out an appendix or taking out gallbladders and things like that. The more advanced stuff is more unusual, and you kind of have to go to specialized centers. That would be the more advanced or the bigger ventral hernias. In other words, abdominal hernias, particularly if they're in an incision from a previous surgery. A lot of the groin hernias that we can do with the camera now, the anatomy is very different, and those are very difficult to do those either. And then, of course, the colon resections, removing somebody's spleen, all those kind of things are very specialized. And you can actually fix holes in diaphragms and fix hiatal hernias laparoscopically too. So all of that stuff is specialized. And we also trained on using the cameras, but actually thoracoscopic, in other words, resecting part of somebody's lung and things like that with the cameras. So, you really, a lot of these things can be done, but they're not done everywhere.
And I saw one of the things you had put down to talk about is the gynecology, the surgeries being done in that particular area.
Right. Dr. Ullman is, right on top of things also, and she's she's the gynecologist, right. And she uses most of the same instruments and does a lot of she does most of the gynecologic surgery there, although a lot of the other physicians deliver and do C-sections. So she actually does a lot of the laparoscopic assisted hysterectomies, tubal ligations. She'll do a diagnostic laparoscopy, as will I, but she'll do it for, say, pelvic pain, infertility problems, those kind of things. And they're now developing a new certification for minimally invasive gynecologic surgery, and she's addressing that. So she's hoping to get in on that certification, and she's doing some additional training so that we actually will be recognized as a minimally invasive gynecologic center also.
So someone walks into the hospital and you're having a gallbladder problem, you're going to have to take it out. How do you determine if you do it this way or the traditional way?
Almost no reason to start the traditional way. There have been maybe only 2 times that I've done that. A lot of times the patient is too sick and they're not going to tolerate it. Certain heart conditions, as far as like say aortic stenosis, where the opening going out of the heart is small, those people, or congestive heart failure, people that have very irritable hearts with bad rhythms, they won't tolerate having their abdomen distended with the air. Or they won't tolerate having the air in the belly because it pushes on the veins and then the blood doesn't get back to the heart. So somebody like that. And then you have people that have what you would refer to as a frozen belly. People who have had multiple traumas, they've had 6 or 8 surgeries on their belly, and they tell you that the last time someone was in there, they said, "I'm never going in there again."
Wow.
Yeah, those are nightmares. You're not going to be able to go anywhere. It's like someone poured super glue. So in those cases, those might be a few places where you'd say, you know, it's not worth the risk. I'm just going to do it open.
How about cost?
Cost-wise, there's no doubt the equipment is more expensive because a lot of this
To do it laparoscopically.
Some of it we can re-sterilize and use, and some of it, the majority is, you know, disposable. So when you look at the flat cost of this versus the typical metal stuff you just re-sterilize, this is more expensive. However, when you look at the larger picture, you look at someone staying in the hospital for 5 days for an open gallbladder versus going home the same day, you have a much lower cost because the actual surgery time is less. The cost of the instruments is a little bit more, but you have less nursing costs, you have less in-hospital costs to the patient and to their insurance company, and quite frankly, you have a much better productivity. Laparoscopically, I can get people back after a gallbladder, and they may be working the next day or 2-3 days later.
That's really incredible.
Where, yeah, and you're not even gonna be out of the hospital if you have an open procedure. So, you know, if you look at just the numbers in the operating room, it's more expensive. But when you look at the bigger picture, as far as length of stay and productivity, you know, nationwide, laparoscopic is definitely the way to go if it's a safe option for the patient. Everything revolves around whatever is safest for that patient at that moment.
Just, we have about a minute left, but what about the insurance issues? Do insurance companies, do they?
The insurance companies really would prefer to do it laparoscopically, obviously, because the length of stay is so much shorter. Oh yes,
Okay.
it is. You know, when you look purely at the dollar cost, it's probably a little more expensive to do a laparoscopic surgery. But the turnaround time, the faster the patient's back, the less hospitalization charges, all of that is much more efficient for an insurance company.
Right, less disability claim, all that kind of thing.
And less invasive to your body in general. So the frozen belly syndrome, as Dr. Mahoney called it, isn't going to happen to those people that, you know, are having these surgeries now because they aren't having these big, huge incisions from previous surgeries. So.
Well, this has been very informative. I hope that this is the only place I ever have to look at these tools and I don't have to come to your studio to
I
do
leave
this.
nice scars. You can still wear your Speedo.
Yeah.
But thank you very much for appearing on the show. We appreciate it very much.
Thank you.
Cindy
for having
Swenson
us.
and Dr. Patricia Mahoney from Lakewood Health Systems.
Thank you.
You've been watching Lakeland Currents, where we talk about what you're talking about, and maybe you haven't been talking about laparoscopic surgery, but now you have a better idea of what it's all about. I'm Ray Gildow. So long until next time.